Hello, everyone, and welcome to this next episode of the Akal and Koka Report. We are delighted to have again with us Dr. Saurabh Jha, who is making his third appearance on the Akal and Koka Report. Dr. Jha is Associate Professor of Radiology at the University of Pennsylvania Perelman School of Medicine in Philadelphia, and is well known for his prolific, insightful, biting, and often hilarious writings and commentaries about medicine, which are published in blogs, in the lay press, but also in the most prestigious peer-reviewed journals, including the New England Journal of Medicine, the BMJ, Academic Radiology, and many others. Dr. Jha obtained his medical degree from the University of London. He then did some postgraduate training in surgery in London and in Australia before immigrating to the United States for further training in radiology at the University of Pennsylvania, where he is now on the full-time faculty. Dr. Jha is also the host of an excellent podcast sponsored by the American College of Radiology called Radiology Firing Line. And we are delighted to have him with us again to talk precisely about the future of radiology. Saurabh, welcome to the show.
Thank you, Michelle.
So I thought we'd start off with an editorial just published by, who else but Dr. Ioannidis in JAMA just a few days ago. John Ioannidis, who's notorious for trying to clean up the House of Medicine with a big broom. He sees that there's lots of wasted research, wasted healthcare dollars, wasted this, wasted that, and now the focus of his attention is radiology. And the title of his editorial is Curbing Unnecessary and Wasted Diagnostic Imaging. It's an editorial that he co-authored with Ohad Oren and Electron Kibabu, and I'll have that on the show notes on akalandkoka.com. Basically, I'll give the gist or the bullet points of the editorial. He says there's a lot of wasted imaging. I think we're all in agreement on that point. And then he wants, he appeals to, quote, well-orchestrated strategies that are needed to reduce unnecessary diagnostic imaging. And then he lists, 5 or 6 different possibilities. One is education. We should educate doctors and radiologists about necessary imaging and unnecessary imaging, number one. Number two, maybe we can educate the general public and tell healthy individuals that screening can be wasteful and that sort of thing. Bullet point number 3, educating the general public may not be enough and maybe too remote from the point of care, so maybe we should have education at the point of care. So imagine a patient going to get a test. Bingo, there's a little app or something that will tell you what the specificity and sensitivity of the test is, so that the patient can proceed with the diagnostic imaging with full knowledge of the limitations of testing. And then finally, there are some technical some technical solutions. One would be to put blinders on the radiologist, reduce the field of vision so that the radiologist only sees what they're asked to comment about and do not see other parts of the body that are in the vicinity, and they so that they won't be tempted to make comments about everything else that they see on the images. Or you could blur the image that is outside the field of concern, and that sort of thing. And finally, you could increase the cost of non-indicated imaging, so some kind of price incentives or disincentives against imaging. And then, last but not least, you could have radiologists who approve or disapprove of testing. The same way that infectious disease specialists approve or disapprove of high-potency antibiotics, you can have some radiologists play that role. Dr. Jha, what are your thoughts?
Right, it's a bit of a handful to take in.
Of course, he ends by saying that, randomized control trials are needed, because without randomized control trials, we will never be able to sort that out.
More research is needed.
Correct.
Yeah. Right. The article went typically down the sort of technocratic route that it does, what are the solutions? Education, education, education. It almost sounds like Pink Floyd in reverse, doesn't it? Except he says we don't need no education. Education, strategy, guidelines, ionometer, off the scale. Oh, I mean, it's 5 years too late. I mentioned all this stuff in 2013. But anyway, what's intriguing about that editorial is there's not a single radiologist on it. So here are people that don't practice radiology, that is pontificating and telling radiologists what to do. And that's fine. I'm used to people telling me what to do,
Right.
except when I tell them what to do.
Do they even practice medicine? I mean, I don't know. Right.
You must control imaging. Okay. You might not want to get that test. No, not me. Somebody else, because we're all fine. And that's the problem that you have with this gatekeeper thing, is that every physician that I've met, I haven't met a single physician. It's funny that, I've been at Penn for a long time. One of the physicians I once encountered was ordering a second MR venogram. Long story, but I didn't think it was terribly appropriate or was going to yield anything. And this particular physician had given long lectures on appropriate use. And I said, you gave a long lecture on appropriate use. And he said, oh, yeah, but, I'm okay. It's everybody else. It's everybody else at fault but me. It's typical tragedy of commons issue. And then the other problem, of course, is that radiologists don't want to gatekeep. Firstly, people don't want us to gatekeep. The moment we start asking why, they're like, I remember once I asked an emergency physician. I was a resident at that time, just come back from clinical medicine. So, being a doctor, that stethoscope, the lub-dub, was still in my ears. Lub-dub, lub-dub, third heart sound, fourth heart sound. So I asked the emergency physician, why are you suspecting PE in this patient? What's the D-dimer? What's the Wells score? He goes, well, how's that going to help you find a PE? He had a point, right? P's either there or not there. And me inquiring about all this stuff, it's just you stop wasting your time. Go find the P that we're asking you to look. So firstly, people don't want radiologists to. Secondly, radiologists don't want to gatekeep. Radiologists want to do their work, read the study, demolish the list, and go home at 5 p.m. Thirdly, and I hate to say this, I don't think radiologists can gatekeep because I think their clinical knowledge is not that great. I mean, the whole point of gatekeeping is actually being able to know what the clinical picture is, what the alternative diagnosis is, when a test is going to be negative, and you need to understand clinical medicine. And I think that by virtue of the fact that you can get into radiology now with just your internship, which is a lot of bullshit anyway, just a scut monkey the whole year, you don't need to do any form. I did a board I boarded in surgery, half boarded in medicine. I'm not blowing my trumpet. This is what you have to do in England to get into radiology. And so, so the clinical element is gone. Plus, there's no need. So whatever clinical medicine you knew gets atrophied over time. So I don't think radiologists can gatekeep. The most you can do is say, look, that's really atrocious. You don't want to give oral contrast if you're suspecting esophageal left atrial fistula, because you won't be able to see one. That's the best you can do. The best you can do is say, oh, that supine radiograph that you asked to rule out the patient's lying flat, it has a sensitivity of 10%. I'm exaggerating, it's probably less than that. That's the best you can do, is you can just simply say, look, that's totally idiotic. But beyond that, there's no gatekeeping. The other suggestions of the group, the education bit, I think that's been tried, right? People have tried.
I'd say, right. I mean, it's what, 15, 20, 30 years of essentially appropriate use criteria through the EBM movement. Right. And then you've had this clinical decision support, and people hate it. When it keeps flashing in front of you and says, "Oh, that's low indicator." You know what they wanted people the CDS is supposed to do? They wanted to not bug them with this low indication. This is not what's called a hard stop. They wanted to remove that. People don't like that. That's been tried. And educating the public. What are you going to educate the public? When you go to the emergency department thinking that you have a heart attack, don't ask for a cardiac CT because it doesn't improve the outcomes. Oh my God! So Jack is going to worry about outcomes for Rajiv and everyone else. This is just total daftness. And one thing that this editorial doesn't mention is that this fear of missing stuff. The fear of actually having a false negative, missing a dissection, missing a pulmonary embolism. What about that? How about educating people and say, look, mate, shit happens. There's a 1 in 100 chance shit's going to happen. We'll pick up the big P's, but, you come up with a bit of an atypical presentation. We don't want to pick up that adrenal gland, therefore we shouldn't look for a PE. It's all daft, unmanageable,
unimplementable. The one thing I did like, and a lot of people make fun of that. The one thing that I did like, which I think showed a little bit of insight, was this restricted field of view. I think there is a point there, but let me just tell you what the problem with that is. I once actually suggested to my section, actually at a meeting, that
So
when
let me just summarize, because the audience may not be clear on what we're talking about. It means that if I order a test for, let's say, I'm concerned about the abdominal aorta and order a CT, that you would just have the machine will automatically acquire all the information around the aorta, the gut, the liver, the this, the that.
right.
And essentially, what Ioannidis is suggesting is to just have the field of view only show the aorta, what was requested by the doctor, and nothing else.
I think this is sort of where you kind of needed to understand a little bit of anatomy. The aorta, unfortunately, has branches, and it also bifurcates into the iliac arteries, which go from posterior to anterior. I mean, I know it's a bit not really intelligently designed, but nevertheless, that's what we have.
Right.
And dissections sometimes go all the way to the common femoral arteries. What are you going to do about that? But I think the basic gist, I don't want to make too much fun out of it, because I'm only allowed to make a little bit of fun out of that particular paper. The basic gist is correct. So what happened was I actually suggested to the department that, when you follow up these lung nodules and it's in the right upper lobe, just restrict the field of view to the right upper lobe, because that's where the lung nodule is. So anytime you make a suggestion, there's always a clever person that comes up with a smart answer. Oh, but how do you know there's not metachronous, synchronous cancer? Oh, for fuck's sake. How are you going to deal with people that think they're really smart, who come up with, plausibilities, improbabilities were there? That was one problem. The other problem, somebody said to me, the other suggestion, the other counter was that you can't do that because that's fraud. So how's that fraud? Because you're obviously billing for the entire chest. I said, well, hang on, you're just doing a third of it. No, but you need to include the whole chest and the heart because you're billing for it. Why can't you just not bill for it? Because there's no code for that. So if you just did the kidneys, let alone the fact that if you actually had, renal colic, ureteric colic, you have to follow the ureter all the way down to the bladder. Again, transcending various, anatomical domains, various countries. Let alone that fact. But let's say, for instance, you could just do the kidneys. You can't really just bill for a CT scan of the kidney, because the abdomen must include everything else because of some person that came up billing. So you can see that the problem with technocracy is that it actually shoots itself in the foot.
Absolutely, you're right. Because there's nothing in this editorial. I mean, even though the points may be, valid theoretically, it's completely taken out of context of what the reality of healthcare is, right? And there are certain reasons why we do things the way they are, and so forth.
Yeah, it's very,
the cost of acquiring an image is trivial for the people using it, right? For the guy ordering it, the cost of acquisition is almost zero, and then these things. I mean, if the doctor had to pay, or if the patient had to pay for all this extraneous and unnecessary information, I'm sure they would have. Radiology would have evolved in a different way, right? There'd be codes specifically. I mean, you would say, what exactly are you looking for, right? You would design your menu of tests, of possible tests,
right?
Very specific in a much more targeted manner. Right, if people had to be responsible, because there is indeed a cost associated with all this information that we have. That's the point that Ioannidis makes at the end. He says, the cost of there's a cost for too much information, and that's correct.
So I was trying to do my Donald Trump wrong thing, but
all right, go for it.
You kept talking through. No, but the problem is, in healthcare there's a massive asymmetry of information. So. You have in India where, I'm getting calls for my 86-year-old grandmother who's in the hospital, and my uncle is calling me saying, they've recommended a coronary CTA for her, and we're going to go get it because, I'm scared, and, they didn't explain much, but she needs this coronary CTA. And it's only when I get on the phone with some random person there who is perhaps receiving some, I don't know what exactly deals they have going on there, but, there's no solid explanation for why do you want to do a coronary CTA on my 86-year-old grandmother who had AFib for 10 seconds? So, you know, I think it's not in a perfect market what you're saying may work, but it certainly, healthcare doesn't seem to be that. So how do we just simply giving the patient the ability to pay, meaning making the patient feel the cost of it, doesn't necessarily curb the real problem that Ioannidis is talking about. So I'll ask both of you, smarty pants, how overuse certainly does seem to be a problem, given Ioannidis does not move the ball forward in terms of figuring out how to do it. How do we exactly do this? Dr. Jha has much to say about this from his editorial that he wrote 5 years ago now, right? Or how long ago?
Yeah, the gatekeeper one.
Yes.
Yeah.
Wonderful editorial.
I don't think it will work, to be honest. I don't think anybody really wants to gatekeep. I mean, the solution really would be that you take a.
Well, sorry, go ahead. Tell us what you said in your editorial.
Well, essentially, what you want radiologists to do is to erect a barrier to getting a test.
Right.
Make the getting of the test much more difficult. At the moment, it's a push of a button, and it's getting easier and easier. I mean, you know, we're doing cardiac MRIs on the same day. In London, there's a waiting list for 4 weeks. In 4 weeks, Nature takes its own course. You know, in 6 hours, Nature hasn't had time to take its course, and time is often the best diagnostic tool. So the moment you kind of make the access to MRI that much easier, and we have enough MRIs, that now if you have a 24-hour delay, people start getting anxious. Oh, and then, you know, complaints start coming in. So the structure facilitates, you know, imaging, the access of imaging, ease of imaging. You know, when people want to be patient-centered and want patients to not have any delays, then you're really going to encourage more imaging, because you're making it easier to get it. So the way to deal with it is to make it more difficult. And if you make it more difficult, then yes, you will have scenarios where somebody who needed a study won't be able to get it. So this perfect situation where let's reduce waste but not harm anybody, this kind of utopian idiocy that gets fed in and gets regurgitated over and over again, which annoys me to no end. It's not going to happen. You have to accept the trade-offs that come with that. And if you really think that overuse is bad, then accept the false negatives and the misses that will come with it.
So what happens if we incentivize the ordering clinician to be as efficient as possible? Meaning, you know, there's this idea that interesting idea floated about of giving doctors their number in terms of their if you have a Medicare beneficiary who a certain amount is spent, now you know you have responsibility for that number that was spent, correct? So imagine a world where for a hospitalization, the attending that's in charge, right, is graded based on how much money was spent for that admission. So you know, if you're a hospitalist that took a patient for chest pain, your incentive. There's an incentive to be more cost efficient. And by the way, you still have the knowledge that if I don't do any testing on anyone and somebody leaves the hospital and has an MI, I am going to face a lawsuit as well. So how about that as a mechanism to solve this?
Well, you've got a kind of a partial history of that, don't you, with the managed care organizations. And managed care organizations occurred at a time before the imaging boost happened. And despite the fact that imaging wasn't as big then, you didn't actually have multi-detector CT, you didn't have MRIs left, right, and center. The restriction that was placed on the imaging that was there, on the VQ scans and catheter angiograms, nobody liked it. The physicians didn't like it, and the patients didn't like it, and the backlash to managed care is so immense that they came up with a accountable care organization and said that's not managed care, which is hilarious. But they had to. It's like your wife renaming you because of your Twitter backlash, saying he's not Anish, he's Manish. but he looks like a niche, and he tweets like a niche, and he's poking everybody's eyes, but he's not a niche, he's Manish. So that's exactly what happened with managed care. He just gave it another name, and came up with, fancy names like shared risk and it's all pool. Yeah, and you see what has actually happened there. It's not even trimmed. It's like a rodent. It hasn't even been able to nibble it at the edges.
But the problem is that they don't have an effective way of incentivizing physicians that are efficient, physicians that are relatively low testers. Look, when you go and choose a physician for your loved one, for yourself, you have a certain type of physician that goes along with your general persona, and for many patients, they like conservative physicians. They like physicians that you walk into their office and you tell them they have chest pain, and that person doesn't send every single person who is having chest pain in the office into the emergency department.
You're obviously talking about yourself, right?
Yeah,
but
why did you simply say like me? You got to be more like
me, exactly. So, but nobody's incentivizing that.
Yeah, but
I don't get paid
I understand that
for being a conservative physician. So I'm saying perhaps there's a way to
incentivize that, right?
Incentivize and make folks more conservative, because right now, the hyper nervous person who's just out of fellowship is busy doing a coronary CT on every single person, and they don't face a penalty for that. I'm not saying necessarily they should face. I don't know how to word that, but you know what I'm saying. Meaning, there's no. How do you promote a different culture, a different value system? Wherein I have that conversation all the time with patients. I tell them, because I'm on the phone, and Michelle, I'm sure, gets this as well, where a person is having, it was like, I just passed out, doctor. What should I do? And it's like 8 p.m. on a Friday, and you take a history, and you tell them, it's like, I think you're okay. These are the features that make this seem to be benign. I cannot rule out 100% that this is something totally benign, but I think you'll be okay till Monday, and come and see me in the office if anything worse happens. And again, we have a conversation about the fact that this is not a perfect system and bad things can happen. But this is how I'm trying to make my judgment. So how do we promote?
Right, but you can only do that if number one, the doctor has time, and most doctors don't have time. I mean, even if they're of a more conservative temperament to begin with, you put them in a mill where they have to see a patient every 15 minutes, and you'll see their ordering behavior, change completely and go through the roof, just because the ordering becomes a substitute for the time that they've lost. They don't have time. The care is fragmented, right? So if the doctor knows that he's going to be able to follow the patient over the weekend without having to turf to a nurse, an on-call nurse in the middle of the night or on the weekend and so forth, then the doctor may be more willing to take the risk of not ordering the test or sending the patient to the ER, because they're going to be they're going to have that relationship. None of that is in any of those recommendations. So all these indictments against wasted healthcare and all that stuff never address the fundamental issues that the whole system is at the core is completely dysfunctional. Yeah. And so if you're going to say we need to incentivize, and you're going to incentivize blanket-wise, we're going to say, oh, everybody, we're going to, no, I mean, the truth is sometimes you want the test, and sometimes you want the test very quickly, right? And it depends, right? The answer is it depends when. It depends. It depends each time. It's a different situation.
That's very true, right? But how do you, in aggregate, right, out of 1,000 patients, is it fair to say that, certain folks will test at a level that, should we be deciding? Should we be trying to guide the hand of physicians somehow to move to a different, more sane world where we don't necessarily, like, I know of physicians that every time they're consulted for renal failure, every single time they rule out multiple myeloma. Like, it's unbelievable. Every single person.
Right, because it costs him nothing. So the only way it will hurt that doctor is if the patients start paying the brunt of his workup. So you keep saying well, let me go back to that point that you were making. Is there more unnecessary care, unnecessary imaging in the US or in India?
In India. No, I don't know. I don't know the actual numbers.
But
Saurabh?
imaging in India. But
I'm sure it's a lot more here than there is in India.
I don't know, but I don't know.
I think,
How do you know?
You just have to look at one other thing. So I think that the market issue is an important issue, but there's another bigger issue. I mean, even bigger than market is another issue. So when George
bigger than market, how can there be? How can nothing bigger than markets?
So when George Mallory was asked why he wanted to climb Everest, you know what he said? Because it's there.
Mm-hmm.
The biggest driver in my experience of imaging is the fact that it's there. It's there.
But it's because it's there in a non-market setting. It's there in a subsidized form. It's there below its market costs or its market price, right? It's there for free. So it's there for free. Then you're going to use it. If you're going to have to convince grandma to put half of her savings on paying for an MRI machine, grandma is going to be a lot more reluctant. Now in India, you give me an example. Maybe it's an exception.
No, India. But in India, it'll be much cheaper, but it'll be used. It'll be still used a lot. So the question is, what are we trying to solve? Are we trying to solve a problem?
Well, but then maybe the market has become so efficient, then it's not a problem anymore. I mean, if there's no scarcity in imaging, then we don't have. There's nothing to solve. Get all the tests that you want.
No, but Ioannidis is saying there is a problem. Ioannidis is saying, and this is a reasonable discussion to have. Meaning, if the cost of a CAT scan actually was $5, right, in our current world, do we still want every single Tom, Dick, and Harry getting a CAT scan?
Well, there's the cost of the incidental findings that are going to be we have to take into account as well, and that. The market, in some fashion, will take into account better than any other option. I mean, I'm not saying it's going to take care of it perfectly, but it'll be better than any other option.
Possibly, but there are two other things over here. The first is that the availability of imaging, the ease of it, actually ratchets up the uncertainty. There's certain uncertainty that you have, and once you know that you can get a CT scan in 5 minutes, your uncertainty increases, or rather your intolerance of uncertainty increases. That's the first thing. The second thing is that even though we know that excessive information can be harmful, if you've got somebody who's worried, or you're worried, that there is a small but not zero chance of an aortic dissection, the adrenal nodule that you might pick up incidentally is a second order concern. There's a chance you're not going to see that adrenal nodule. So you can't be concerned about something that's not there. You're concerned about something that could be there. It's a slightly different calculus. It's hard to be worried. It's like saying, I need to take an emergency flight to see my, ill relative, but there's a small possibility that between the airport and getting home, I might get knocked over by, there's a small possibility of that, but the overwhelming concern is that particular thing that's driving you. So, I think the dynamic is a little bit more complex, and having worked in the emergency department, and seen others work in the emergency department, we were more tolerant of uncertainty. We were more tolerant of being wrong, or we were more decisive. And we were wrong. There were some false negatives. We missed things. But we also knew that we couldn't get CT scans left, right, and center. So we had to, make decisions. And the spectrum, obviously we didn't say to somebody who had, rigid abdomen with peritonitis, all right, go home. We're not sure about you, but the gray zone, the kind of, the what seems like to be gastritis or not pancreatitis, the labs are normal. A few of those turn out to be perfs. You'd be 2 out of 1,000 of those presentations would turn out to be a perf, because not all perfs present in the same manner. Mm-hmm. The intolerance of uncertainty is to a large extent driven by the ease of availability of imaging. It's very hard ex ante to be concerned about something that you haven't found. You can't be concerned about an incidental finding. I think this idea of shared decision making is also slightly idiotic, because the patient doesn't come to you to get the expected value of the various pathways. You tell them, Dr. Coker tells them, you don't have a heart attack, go home, and I'm your doctor and I'm competent. They'll believe that, but they're not here to hear about, well, you could have a heart attack. It's small, but there's a chance that if we try and find it, we might harm you by finding an adrenal nodule. They say, well, what the hell's wrong with you? Have a heart attack or not? And I would say that. I would think about the first order phenomenon, not worry about the second and third order phenomenon.
I agree. So, I mean, I think the proposal put forth in this editorial may be wishful thinking. Next topic: can AI,
the proposal,
artificial?
But Saurabh has come to the conclusion that the original editorial he wrote was perhaps also not practical.
No, it wasn't.
Would
I
that
got
be
a
fair?
lot of pushback from
Yeah.
radiologists who told me
Yeah.
that I was talking out of my posterior. I probably was. It's known to
Right.
happen.
I mean, I think.
But-
Right.
But I think I've come to the conclusion that radiologists do not wish to gatekeep. They don't wish to be involved in. They like the no. Don't get a barium enema. Get a small bowel follow through. They like that. Maybe you don't want the steak. Maybe you want the duck tonight. It's a special. But they don't want the. No, you shouldn't have the steak or the duck or anything else. To go home and not eat. They don't like that.
Right. I agree. Next topic. Well, same topic, but a solution not offered here. Can AI come to the rescue? Artificial intelligence.
Well, let's kind of go back and see what AI actually means for radiology. I don't think it's going to necessarily help with the appropriateness, but the question is, can AI do some of our tasks and do it better? And I think the answer certainly is yes, it can, because for multiple reasons. The first is that radiology has changed a lot. When we were just looking at chest radiographs and projectional imaging, two-dimensional, is actually more complex then, because there was not a lot that you could see, and there was actually a lot of clinical information that you needed to integrate. There's actually a really funny story. There's this guy Felsen, who was a titan in chest radiology, huge, big person in chest X-rays, and he was showing a depiction of interstitial lung disease, and it was a time before PowerPoint, so it was like this carousel that moved around, and he gave each disease and he gave a name, like this is interstitial lung disease, this is interstitial pulmonary fibrosis, this is emphysema, this is alpha-1 antitrypsin deficiency, so on and so forth. And then he came to the last spoken slide, because the written and the pictures were different, and he realized that he had actually had one picture left. So every chest X-ray that he showed was actually
off by one.
One. Then he looked at the audience and said, "That's all right. They all look the same anyway."
Right.
And so, what was true at the time was that radiologists were extracting imaging findings and also the clinical history and merging the two together to get some sort of differential diagnosis. Now, with CT scan, you see things a lot better. And then the third wave is, so you got the CT and the MRI, and the third wave is the quantification. So there's less ambiguity to what they can be. There's less kind of gray. There's more black and white, although it's not technically black and white. It's just a Gaussian distribution. Every finding itself is like a bell-shaped curve. So on top of that, now you have guidelines that pretty much tell you what to do in a lot of scenarios. If you find an adrenal nodule and if it measures less than a certain value, what would happen before was some radiologists say follow it, some wouldn't say follow it. People didn't like the variation, because variation makes us seem like idiots, although people don't realize why the variation occurs in the first place. So now what they say is that you all follow the nodule in exactly the same way. So now you don't have variation, but everybody's wrong in the same manner. Mm-hmm. So some people think that's progress. I think that's just regression. So now you see a nodule and you have this guideline, you have a category, you have there's a lung rad, there's a birad, there's a pyrad, there's a tirad, all of these are categories of 1 is benign, 5 is definitely malignant, and you bark it into your dictaphone. That doesn't require a medical degree. That does not require a medical degree. So before we talk, before people get into the nitty-gritty of AI, I think it's important to understand what is it that radiologists do that requires high level of cognitive expertise. I'd say 25% of what we do is extremely high level, of both visual and cognitive, the kind of understanding of the imaging, bringing together the clinical picture. 25% is complex. We could do it better, but I'd say about 10 to 15% could be more complex if we wanted it to be, but we just bark into the dictaphone multifocal airspace opacities, lung, blood, pus, water. And if we understood a little bit about the physiology and about the wedge pressures, we could probably come down a bit more on that. But I'd say 30% of what we do does not only require a medical degree, but also doesn't require high school. It can be done by anybody, and that should be taken away by somebody. We're overpaid to do that sort of stuff. And the challenge with AI is a computational challenge, but it's kind of making sure that they're good at actually doing that low-lying stuff. But as far as should it be taken away from us? Absolutely, it should be taken away from us. Now, the issue that you have is that with AI, what a lot of people didn't realize at the beginning is that, some did, is that AI is only as good as the data you feed it. And the data that's fed needs to have a gold standard, needs to have a proper label. Otherwise, AI is going to be hedging just like radiologists, which isn't going to be terribly helpful. So it's getting those proper labels through. That's the first thing. You need to have proper labeling and ground truth. The other thing is that the way the algorithms are actually progressing, they're all kind of one-trick ponies. So you have an algorithm for breast density. You have an algorithm for, the heart, for calcium scoring, for ejection fraction, we joke, there's radiologists are so subspecialized that you have a radiologist for the right adrenal gland and left adrenal gland on call, but you can have an algorithm for each. So you've got these little one-trick ponies that are emerging. So how are you going to put all that together is going to be a little bit of a challenge, and I'm not sure anybody's really come out with that, how to kind of bring it all together, be more holistic. But I think that things deserve to be taken away from us.
Right. So, you said something just a minute ago where you talked about, you said that before we had these guidelines for how to deal with nodules of a certain size and whatnot, there'd be some radiologist advising one way, another radiologist advising another way. Is it ever possible, do you think it's even conceivable that at some point Anish or myself as independent doctors would be able to send our patients to some independent radiologist or independent radiology group that whose judgment we trust, who doesn't necessarily give us is going to spout the typical guideline stuff? I mean, what a loss, what a shame that we've come to that point, and that speaks a little bit to what you're saying here regarding what really what requires a medical degree, what doesn't require a medical degree. I mean, if you're going to be interchangeable, essentially you've answered that question. On the other hand, you were not interchangeable, right? You've been made interchangeable by the desire to standardize everything for the sake of the system. On the other hand, I'd like to have a real flesh and blood radiologist I can, speak with, and who's going to some extent be, continue to be, at least be partly accountable for the decisions that are made in a patient. But I don't see that happening. I mean, I think that's completely wishful thinking on my part.
The DPC model isn't easy for radiologists because
right.
Our entire business structure is funded by a third party. I mean, we should actually love government. We should love big government. We should love insurance companies because we suckle at the bosom of big government much more. If we went free market over here, we'd collapse. The business model would collapse. But but to your point about the flesh and blood radiologists who can give you something that's not standardized, I think there are two issues here. The first is that arbitrariness, the gray that you had with the chest X-ray, there truly was arbitrariness, evidenced by that, all interstitial lung diseases look the same. What has actually happened with cross-sectional imaging is that there's not that much that you can really stray. You can have some variation, and the reality is people haven't even tolerated that variation, that degree of variation. But if you have a polytrauma, there's not very much of an opinion to have if the rib is fractured or not. So with cross-sectional imaging, it's kind of brought us down to earth in a sense. So, but that's not to say that there's no value of somebody that. But
isn't that a threat then to? I mean, if at this point the judgment doesn't really matter,
Yeah, I'm kind of lamenting as opposed to offering any solutions over here. But I think that the scope of judgment has become narrower and narrower. Um, I mean, the one thing that you can do, which many radiologists do to their credit, is that if you have a chest CT, for instance, you can, by virtue of knowing where the patient, where the referral is coming from, their background history, in the lungs are, lungs are the common pathway a lot of things. So if you know the patient's oncological, if you know the patient has immunosuppression, patient is prone post-transplant, you can modify your differential diagnosis there. So I think there's certainly value there. There's also value, in my opinion, of the radiologist being embedded in areas of clinical decision making, because there's a lot of back and forth that can happen by imaging that's already happened without the need for new imaging. So this idea of the consultation, it's not only conditional upon the imaging being present, it can also happen from a dialogue, providing that you've
Right.
got.
It's true. I mean, as it happens, I speak to radiologists a lot, and I find that those are the most enlightening conversations that I have whenever I call a radiologist regarding a test that I've ordered, or sometimes even before I order the test. But
what do you like? What kind of questions do you have for them? What's the conversation?
I mean, I'll give you an example. I mean, somebody had there was a soft mass. I couldn't tell if it was a lipoma for sure. It seemed deeper and a little firmer. It was right, over the one of the ribs. And I wanted to know what's the best modality. Should we start with ultrasound, whatnot? Then they actually got the ultrasound, and then the result was not all that clear. There was some recommendation from the radiologist, but then I needed to know, do we plan a biopsy at the same time when we do a CT, or do we do a CT first? That sort of thing. It's educational for me, and it's it was rewarding. I felt that I wasn't just ordering a bunch of tests and so it's actually there. I'm in a unique position that I actually have the luxury time to do this. I mean, I think most primary care physicians don't, right? And go ahead.
I think what Saurabh has said is really enlightening. Is that where humans or radiologists have most value is in areas of greatest uncertainty. So. So for instance, stress CMR, right? Stress cardiac MRI. There's an awful lot of gray in there, partly because stress CMR is not at the level of cross-sectional imaging to see if a rib is fractured or not. So there's a tremendous amount of back and forth that you have between the radiologist and the clinician about what exactly and how to interpret that stress CMR. So it's interesting, but it does feel like, for say chest X-rays, where we all as clinicians look at our own chest X-rays, certainly in the hospital, as we're trying to figure out volume status, trying to if the patient has a fever, we order a chest X-ray. Most clinicians, most attendings, I would say, are looking at these X-rays themselves, it's not so much that but we're not nearly as good as the radiologists are looking at X-rays in terms of picking up a variety of different findings that we ordinarily wouldn't see. But in terms of what it is of interest that we want to know, we usually have a sense if that opacity that we're seeing, we usually have a better sense, I'd say, a lot of times than the radiologists about whether this is pulmonary edema or whether this is, an infiltrate that represents a pneumonia. But what we're terrible at, what we're bad at, is the incidentaloma that maybe exist within the chest X-ray that we don't have the experience and aren't as good at looking at. So that patient may have the reason I want the radiologist reading the chest X-ray is not so much because I want him to tell me, or want her to tell me whether it's a pneumonia or pulmonary edema, but more so if there's some lung mass that I'm not looking for, that they are looking for. And that's where I guess AI may be very helpful to a clinician, because if AI can approach can approach that level of the of an experienced radiologist for catching that other stuff, then perhaps we don't need X-ray techs or humans at all reading that kind of stuff. Does that seem like a reasonable?
Yeah. So
assessment?
there's always going to be tasks that AI can get to. When AI gets to a particular task, depending on how common that task is, you're pretty much shrinking the workload. And then what you have is you either have the existing workforce doing other things, or you have a smaller workforce doing the same thing, all things else being constant. So a lot of imaging is obtained for line manipulation in the intensive care unit. With the nasogastric tube that gets advanced 4 centimeters every time, then first it goes past the tracheal bifurcation, and that's in the esophagus, then the GE junction, and then whoops, it's in the jejunum. Let's put it back a bit. 6 X-rays, and for all of them, you've got everything is the same, but you still have to put in that still standardized report: lungs, heart, bones. It takes time. It takes time to get that NG tube right in the, and that time is taken by experienced people that have a medical degree. And if AI does that, you're pretty much freeing FTEs. So you're either shrinking the workforce, or you're getting radiologists to other things, such as going into the intensive care unit, if they choose to do that. Or as some say, we'll just read faster, run faster on the hamster wheel.
So right.
It's how you kind of slice and dice it.
So is it in anticipation of perhaps the decreased workload that some radiologists now are calling for radiologists to meet with patients and see patients?
Yeah, I'm not really quite sure what that's all about, to be honest. I mean, we've been talking to patients for a long time. It's quite a misnomer that, your typical view of a radiologist is this recluse Norman Bates with a motel who stabs women in the shower. I don't know many radiologists that do that. The reality is you do speak to patients, and particularly some exams, you actually have to have fairly good communication skills. So like a barium enema, for instance, a retrograde urethrogram, particularly the barium enema, where you're inserting contrast, and you're getting, you're moving the table and stuff like that. So, and also with ultrasound.
Right, but that doesn't. It's not a conversation that rises to the level of what we would consider a doctor-patient relationship.
No, so then it comes to what exactly does that mean? So I think what a lot of people are saying is that we have to disclose the results to the patients. And again, there's the low-lying fruit there. The low-lying fruit is if you've got somebody who comes, young man comes in with testicular pain, and you do the ultrasound and you don't see a cancer, it's lad, wait a week to find that out. So you're right there, you say, look, I haven't found anything, or there's a hydrocele, you don't need to worry about that. So there's that. And then the level of decision making gets very complex. I once actually had a case where for coronary CTA, it was thick and spack normal. A young man, coronary CTA, and I just went up to him because I looked at it on the scanner and I said, this is just so obviously normal. I looked at the lungs as well, obviously normal. I went up to him and said, I introduced myself, had a bit of a conversation. I think it was around the time of the 2016 election. I even asked, are you going to vote for Trump or not? So you can see that what would happen if you have a doctor-patient relationship with a radiologist. And I said, your coronary arteries are spick and spack normal. And then the next thing he said, well, why am I having this chest pain? What's wrong with me? I mean, I don't think that my answer pleased him. And so then I said, well, I think you need to go see your doctor, which I think was a very unsatisfactory conversation. After all of this, all you're saying is, well, actually, you probably going to need to see a doctor. So immediately I phoned up the cardiologist and said, look, I actually had a conversation with him and said to him that the coronary arteries are normal. I said, all right, don't worry, I will follow this up. But, it was more than a reassurance test. It was a test of what's wrong with me. It was like there was a quest to find out what was wrong with them. And you just barge into the doctor-patient relationship and give somebody a bit of information, and you just go home as if nothing's happened. And I think that model is incorrect. Some radiologists are saying, look, what we can do is we can actually sit with a patient and show them their kidneys and show them their, and that's fine if the renal arteries are normal. You can then, how we generate these pictures. Like, that's your upper pole, that's your lower pole, that's the ureter coming out. Have a look at that. But if it's anything complex, then patients will ask you, well, what am I going to do next? What am I going to have surgery? So it's not to say that you can't do that or you shouldn't do that. Say that we need to think it a little bit more carefully.
Yeah, I agree. And in fact, I mean, my gut feeling would be to say maybe you shouldn't do that. I mean, unless you're doing it in the presence of the clinician who's going to be ultimately responsible for the whole conversation, right? Because otherwise, it's more cooks in the kitchen and more possibility for more problems and perhaps more unnecessary testing.
Right, because now you spot a lymph node, which you would have buried in the bottom of your report, but now you're kind of obliged to say that.
Right. And the clinician may actually choose not to mention it or that sort of thing. Right. Very good. Well, I mean, I think it's interesting. I don't know that radiology is a bellwether for where the healthcare system is going, but on the other hand, it has a special place, by virtue of the fact that it is so technology intensive. And such a, in a way, an obvious target to try to, for the technocrats to try to manipulate.
Yeah.
That it's an interesting field to follow, and see where it's going. Again, if I had my wish, radiologists would be independent. They'd have their own centers. They would really, whether they're actually physicians or not is kind of immaterial, but they play a vital role for the physician, and they would be essentially the ally of the clinician. Right now, they're in a position where they're part of the hospital system, right? The radiologists primarily have a contract with a hospital or a hospital system, and I think by virtue of that, their position is a little bit difficult, I would say.
There are some independent radiologists, but yes, it is a growing trend that they're going towards the hospital system. No, I think you're right. They are fundamentally doctor's doctor. We are fundamentally doctor's doctor, and it's I kind of liken it. Although I know aviation analogies aren't rage these days, but I kind of liken it to air traffic controllers in a sense, where you need to have fluency with the pilot, and the back and forth between them has to be rich in medical terminology. And sure, I mean, you're obviously responsible for the patients, but your job is to help those who help patients, right? To treat those who treat patients, so to speak. So, that is, I think that when people talk about radiologists moving away from the dark room and AI helping with that, I think, yeah, by all means speak to patients. But the first thing you need to do is to speak to clinicians. Clinical decision making is happening at least once in a while. The next thing to do is actually, to be at the scanner whilst the image is being acquired, and on occasion, obviate the need for a contrast, mm-hmm. or extend the field of view. So there's a lot that we still have to do, but I do agree that we need to move away from the dark room and just simply reading film model.
Anish, any final words?
No, I think it's going to be tough because there's a certain selection bias that applies to folks who become radiologists. Do you think, is it the case that a lot of folks that are choosing radiology do it because they are attempting to insulate themselves from that type of patient
interaction?
Patient interactions? I mean, is that not an appealing part of the job for some?
It's not a very politically thing to say, because people get their tails up and get very defensive. But, if I loved speaking to patients and it's something that I would, die for, something that, drove me, I'd become a palliative care doctor. I wouldn't even be a cardiologist, by the way, because you guys spend a lot of time just watching people run on treadmills and have them sedated and put transesophageal probes down their esophagus. I think there are some there are some fields whose primary, modus operandi is actually talking to patients. It's the closest that the one profession which talks to people all the time, non-stop, are barbers, right? I know you don't like barbers. High blood pressure better than you. I know you don't like that, but barbers they talk to people. So what's the barber equivalent in medicine? I'd say it's it's palliative care, or even perhaps emergency medicine. But certainly even surgeons, for instance, they don't talk to people all the time, and certainly anaesthetists, they talk to people only to put them to sleep. So in the overall scheme of things, radiology isn't a patient-facing specialty, but nevertheless, I think that there is interaction, and to be fair, the mammographers, the breast images, they talk to patients all the time. The ultrasound people also do, and pediatric radiology does as well. At least talk to the parents. So the myth that we are insular people that can't stare you in the eye and nibble our nails like this, and play video games, Fortnite, in our spare time,
and stab people in the showers. Right?
Stab people.
Right.
Well, Dr. Jha, I want to commend you on your breaking the stereotype of radiologists as introverted, antisocial folks. So.
Well,
good job.
My tweaking count as my extroversion. That's just.
Thank you very much. We'll see you on Twitter at Rograd, right?
CCFR.
For the audience, at Rograd, ROGUERAD, and we'll have a link to your healthcare blog page for your rich array of editorials and terrific commentaries. Thank you very much for joining us.
Thank you very much. Thanks for having me.